interesting cases. Now this is what we have done and we have found. It is not to be like it's not like a standard we have to follow it that way. Everybody will have a different decisions to be done. Now with all this information, we really like to know whether that particular eye is good for LASIK, or should we have a better approach or some other approach which is safer. How much correction can be treated, what kind of flap is to be done, what is the diameter, thickness, and what is the treatment zone appropriate, and what should be the approximate ablation depth. We follow this Dr. Bellin's elevation guidelines when it comes to pentacam or any Schimflug imaging based system. The values remain the same. So as we discussed in the previous, the faculty members have told, we have these elevation points, the suspicious, which are abnormal up to a certain limit. But apart from that, we have Dr. Jack Holliday elevation guidelines, who says that we should use aspheric toric reference surface, and if posterior elevation is found to be more than 15 microns, yes, we have to be little careful. And apart from that, if you find any red nipple on the tangential map, which is that magnified thing on the particular tangential curvature, and if it's above 48, we should be little careful. Now, rule of thumb, always, whenever you want to take up any eye, we should always remember that it should not become steep than more than 50 microns, especially hyperopic treatment. When it comes to myopic treatment, it should definitely not go below 35 diopters. So you can just get an estimate of that how much K value you will end up with by just adding the spherical equivalent of the proposed treatment. You add it to the average K which you have, and you get an idea. So you can start thinking, just looking at that, okay, can I go ahead with it? And apart from that, definitely the Randleman et al. Ectasia risk score system is the best to, at least when you are taking up the cases on day-to-day basis. You just keep this pasted in your clinic, and it will help you to at least make sure that you will not have any problems. So the score which you get, you use it for deciding whether you want to do LASIK, you want to do a surface ablation, or you should not do it at all. Now we'll look at this 27-year-old woman who is actually a state level sports person. She has worn contact lens for almost 10 years. Everything is fine. Then we look at her manifest refraction. 3.6 is a compound myopic astigmatism. K1, K2s are fine. 46 a bit higher. We look at the PACI, it's 493, 488. But also important is the pupillometry part, because some surgeons give very important to the scotopic pupil or mesopic pupil. And we consider the scotopic pupil to be quite helpful, and also the dominance of the eye is also noted. Now we look at this. The K1, K2 as been discussed. Then we look at the particular thinning part in the thinned out thinnest part over there. It's in the inferotemporal area on the right side. We also look at the we see a little steep surface on the tangential or the sagittal anterior. Apart from that, we find that she's got some 29 posterior elevation, something suspicious, more than 15, 17. Then I look at the keratoconus analysis, and we find that there is a clustering of points in the inferotemporal area. Now all those AK, there are a few indices which were discussed by Dr. K.V. Satyamurthy, which is applicable for other machines also, but it's a different terminology. So this all steepest point and the maximum point, K max, everything is clustering in one place. So I feel, yes, I should be a little careful. Then I look at her left eye, and this is her, the K1, she's got little 46, 47 very higher points, very steep point, inferotemporal. So it's a inferior stiffening is there, though it is a symmetric bow tie. We see some anterior elevation points going up to 34, and definitely on the posterior. Now here we are using an aspirotoric reference surface, because that's what fits on a normal, usually a normal cornea. So we follow the Jack Holliday guidelines most of the time. Looking at her the keratoconus analysis, we do find that there is something. Yeah, I'll just finish it. So taking the ectasia risk score, we find that it is an early indicator of efficacy, so we should better avoid LASIK or PRK. 25-year-old, we have minus 1.5, very simple number, but we look at a keratometry, it's bit of, there is an not argument between manifest and topographic astigmatism, 483, 477. This is how we look at the different points. Look at her left eye. Even with such a refractive error, we think we can correct it, but it suggests there is a form first keratoconus, form FFKC, so we get four are the score points, so we just rule it out. We can't do anything. Should we consider surface ablation with C3R? That's up to the that we have to decide. But there are risk factors, like she keeps on rubbing the eyes, so it's better to avoid this. We have one more case. Actually, she has undergone right eye LASIK and left eye has not been done. She had -1, -1.25. No other details available. This is a post LASIK ectasia. You can note in all the maps it is quite obvious. Even there is a clustering of point in the inferotemporal area. This is the left eye, which has been untouched, -1 cylinder. We see some posterior elevation anomaly. Ectasia is score is 4. Best would have been an advanced surface ablation, but this was done 7-8 years back. So old microkeratomes, flap thickness predictability, definitely a point to be thought of. She might have ended up with a very big flap cut, and she would have been held up with a post-LASIK ectasia. So I think we are short of time, but I think the most of the parameters and most of the indices would have been quite helpful for you to understand. So I would definitely like to have a stop over here. Really thank all the faculty members for giving a very good input, and I would say Dr. Satyamurthy had suggested this particular title, and it really, because we thought about it and it really worked out. Thank you very much. Thank you, Dr. Prashant, Dr. Jeevan Ladi, and thank you, Dr. Gurjeet.